Good day. My name is Christine Marie George, and I'm a professor at Johns Hopkins. And it's my pleasure today to present on our randomized control trial of the Preventative Intervention for Cholera for 7 Days program, which is a WASH RCT of 2,300 participants in the Democratic Republic of the Congo. This research is a collaboration between my research group at Johns Hopkins, Catholic University Bukavu, and the DRC Ministry of Health. The rationale behind our study is that when a cholera patient presents at a health facility, their household members are at 100 times higher risk of developing a cholera infection compared to the general population. And the risk is highest during the 7 days after the cholera patient is admitted to the health facility. And this is thought to be because they're sharing the same contaminated environmental sources, such as drinking water, and through person-to-person transmission, through, for example, lack of hand washing with soap. However, despite this high risk for the household members of cholera patients, there's very limited interventions for this high-risk population. And this led us to our current work on case area targeted interventions for high-risk populations for cholera and other severe diarrheal diseases. And so our WASH work began in Bangladesh with the cholera hospital-based intervention for 7 days, which is a targeted WASH program for the household members of cholera patients. This intervention is health facility initiated, delivered bedside to the cholera patient and their accompanying household members during the time of treatment. A hygiene kit is provided, and then the behavioral recommendations on hand washing with soap and water treatment are reinforced through home visits. And so in the initial randomized control trial of this intervention, we found that the PICHA7 program led to a significant reduction in cholera, which was confirmed by bacterial culture among the household members of cholera patients during the 7-day high-risk period. Building on this work, we partnered with the Bangladesh Ministry of Health and Family Welfare to develop a more scalable approach to deliver the PICHA7 program in Bangladesh, which broadened the scope of the intervention from focusing on cholera patients to diarrhea patients of all etiologies, so that the intervention could benefit millions more beneficiaries, and also replacing home visits with weekly voice and text messages from a doctor at a local cholera treatment center. Our randomized control trial, this more scalable approach to delivering PICHA7 among 2,600 participants, showed that the intervention resulted in a significant reduction in diarrhea, not only during the 7-day high-risk period, but this was sustained out to 12 months. And we also observed a significant reduction in stunting. Leveraging the findings from our work in Bangladesh, the current research focuses on delivering a similar intervention in the Democratic Republic of the Congo, building evidence on case area targeted interventions in a cholera endemic setting in sub-Saharan Africa. Our research program is the Preventative Intervention for Cholera for 7 days. And our research program focuses on investigating transmission pathways for cholera and other severe diarrheal diseases, and developing and evaluating targeted WASH interventions for high-risk populations for diarrheal diseases. Our work is conducted in Eastern DRC. We have activities ongoing in both North and South Kivu, and our work is funded by Wellcome. Through 18 months of community-centered formative research, which included semi-structured interviews and a pilot study of 518 participants, we developed the Preventative Intervention for Cholera for 7 days WASH program. And the acronym is PICHA, and PICHA means picture in Swahili for the pictorial WASH module delivered in the health facility as part of this program. And 7 is for the 7-day high-risk period for subsequent diarrheal diseases among the household members of diarrhea patients. Similar to PICHA7 in Bangladesh, this program is health facility initiated, where a promoter delivers a pictorial WASH module bedside to a diarrhea patient and their accompanying household members in a health facility. They're provided with a hygiene kit, similar to Bangladesh, which includes a hand washing station and a water vessel with lid and tap and chlorine tablets. They then receive home visits during the 7-day high-risk period, and then quarterly visits over the next 12 months. And then they receive a mobile health program, which are weekly voice and text messages from a physician at a local cholera treatment center, which is sent to the mobile phones of the diarrhea patient households. We conducted a randomized control trial of the PICHA7 WASH program between December of 2021 to December of 2023 in urban Bukavu City in South Kivu province of DRC. 2,334 participants were randomized to be in one of two arms. The first arm received a standard message given in DRC by the government on the use of oral rehydration solution for rehydration for diarrhea patients at discharge. And the second arm received the same intervention plus the PICHA7 program. To evaluate the PICHA7 WASH program, we enrolled diarrhea patients and their household members and followed them longitudinally over a 12-month period. We conducted monthly clinical surveillance visits to obtain information on diarrhea episodes. We also measured the height and weight of children under 5 years of age at baseline and a 12-month follow-up. We assessed hand washing with soap practices during 5-hour structured observation and conducted unannounced spot checks to measure free chlorine and assess E. coli in stored drinking water. And now I'll go into our results. We observed that delivery of the PICHA7 program resulted in significantly higher hand washing with soap during food and stool-related events, not only during the 7-day high-risk period, but this was sustained out to our 12-month follow-up. Next, we observed a significantly higher proportion of PICHA7 households with stored drinking water with free chlorine above 0.2 milligrams per liter compared to the standard message arm. Additionally, when we looked at household stored drinking water quality relative to E. coli, we found a significantly higher proportion of PICHA7 households with E. coli less than 1 colony forming unit per 100 ml compared to the standard message arm. Next, going into our health outcomes, we observed that the PICHA7 program resulted in significantly lower diarrhea prevalence during our 12-month surveillance period in comparison to the standard message arm. And again, we conducted monthly clinical surveillance over a 12-month period. This reduction in diarrhea prevalence was not only for children under 5 years of age, but for all age groups, and showed that PICHA7 was highly effective in reducing diarrheal disease in this high-risk population. Next, we looked at the impact of PICHA7 on diarrhea with rice water stool, which is a hallmark sign of cholera. We observed that there was a 52% reduction in the odds of diarrhea with rice water stool during our 12-month surveillance period for participants in the PICHA7 arm compared to those in the standard message arm. Additionally, we found that participants in the PICHA7 arm had a 56% lower odds of a health facility visit for diarrhea during the 12-month program period compared to the standard arm. And these findings show that the PICHA7 program was not only effective in reducing diarrhea among a high-risk population, but also reduced severe forms of diarrhea. Our final health outcome was stunting among children under 5 years of age, which was assessed at a 12-month follow-up. And we found that participants in the PICHA7 arm had a 55% lower odds of stunting at the 12-month follow-up after adjustment for baseline anthro measures compared to the standard arm. Now, I would like to summarize the findings from our randomized control trial, the PICHA7 WASH program. We found that delivery of PICHA7 resulted in a significant reduction in diarrhea prevalence, which was sustained over our 12-month study period. We also observed more than a 50% reduction in health facility visits for diarrhea, as well as diarrhea with rice water stool, which is a hallmark sign of cholera, showing that the PICHA7 program was effective in reducing severe forms of diarrhea. Additionally, we observed that PICHA7 program delivery resulted in a significant reduction in stunting for children under 5 years of age. And consistent with these findings, we found that the PICHA7 program significantly increased WASH behaviors among this high-risk population for diarrheal diseases, which included increased water treatment practices, increased hand washing with soap, and improved stored drinking water quality. So in conclusion, these findings indicate that the PICHA7 program presents a promising approach to reduce diarrheal diseases and improve child growth among diarrhea patient households in the Democratic Republic of the Congo. I would like to end this presentation by acknowledging the contributions of our study participants that participated in this randomized control trial, as well as acknowledging the contributions of my colleagues at Catholic University Bukavu, the DRC Ministry of Health, and Johns Hopkins for their support in conducting this randomized control trial. Thank you.